But good evening, everyone. Once again, thanks for joining in. Somehow I'm unable to see the attendees or panelists. I'm assuming Dr. Shika and Apurva have joined um, from AIMS Nagpur.
Yes, sir.
Yeah, all right. So, okay, without further ado, we think we'll start off with our session. I think we have around 5 cases today. The chat is open. Again, for some reason, I'm not unable to see the chat. That's okay. We'll go ahead with the first case. No problem. All right, Apurva, over to you. Yeah.
Yes, sir. A 13-year-old girl, eight-born of a third-degree consanguineous couple, right-handed child. She presented to us in January 2026 with the fourth episode of left-sided hemiparesis, in which upper limb was predominantly affected with distal involvement more than the proximal. There was also deviation of angle of mouth to the right for 1 day, and both these symptoms were preceded by right-sided headache for 5 days. So her illness began at around 6.5 years of age when she developed left-sided focal seizures with impaired consciousness followed by left leg monoparesis, and this resolved within 7 to 8 days, after which she continued to have recurrent intermittent severe right-sided headaches associated with nausea and vomiting. Around 10 years of age, she again had an episode of severe headache followed by mutism lasting 20 days, suggestive of Broca's aphasia, again left hemisphere involvement, and this also resolved spontaneously on its own. In the year 2025, she had two episodes of similar left-sided hemiparesis in March and July, and each occurring after severe headache, and again resolved spontaneously on its own within a week. On presentation to us, she was alert, conscious, irritable, with stable vitals, and no neurocutaneous markers were noted. On examination, she had flaccidity in left upper limb. Left-sided hemiparesis was noted with areflexia only in the left upper limb with bilateral extensor plantar responses, along with left-sided UMN type of facial palsy. Her rest of the examination was within normal limits. So during the hospital stay, within 48 hours, she developed left focal seizures with impaired consciousness, and which was aborted with anti-seizure medications, and no recurrence of seizures were seen, and her power also improved spontaneously. She returned to her baseline state by day 5 of hospital admission. On her cognitive assessment revealed poor performance in modified childhood mini mental state examination, and her BKT also showed mild intellectual disability. So, considering recurrent transient neurological deficits which were not confined to a specific vascular territory, the symptoms were of gradual onset, always preceded by headache associated with focal seizures, and spontaneous resolution over days, not leaving any deficit behind. Recurrent stroke-like episodes were considered more likely than arterial ischemic stroke. So, on investigations, we did CSF, which was within normal limits, and the rest of the routine workup also was within normal limit. We also did CSF lactate, considering a possibility of MELAS, which can present with recurrent stroke-like events. However, that was also within normal limit. We did thorough systemic evaluation for several fundus, 2D echo, serum lactate, ammonia, homocysteine, ABG, ANA, immunoblot for any vasculitis, any other system involvement, diabetes, thyroid, everything was normal. She did not have any glaucoma or any visual field deficits, any hearing loss. Everything was within normal limits. We did her EEG, and it showed diffuse generalized background slowing. Sir, so this is her summary. 13-year-old child with fourth episode of hemiparesis, all left-sided, always preceded by headache, and which resolve on its own within 7 to 8 days. So now imaging.
All right. Okay, this is the latest imaging done a week back. There were two sets of images. One was a CT done a week prior to the MRI. I have the CT images of the main representative findings, but I think main findings are depicted on the MR. So diffusion various sequences, we do not appreciate any areas of restricted diffusion out here. And on the T2 various sequences, there is some degree of parenchymal volume loss, but no structural malformations, no cortical malformations out there. Yeah, and no focal lesions on the T2 sequences. On the SWS sequences, even though it's the child is a 13-year-old, you can appreciate there is some dark changes on the SWS sequences in the bilateral globus paradigm. And on the corresponding CT, which was done earlier, you have some areas of calcification in the bilateral globus pallidus. No other abnormalities in terms of vascular prominence or vascular asymmetry or cortical asymmetry, cortical vessel asymmetry out there on the SWS sequences. If you can see, there's probably some darkish hyperintensity on the SWS sequences on the right side, but this did not correspond with any parenchymal changes on the T2s or the diffuse sequences. I think angio was done, and angio did not demonstrate any stenosis, thrombosis, or vascular malformations. I think vessel wall imaging also was done, and as you can see, this is normal vasa vasorum enhancement of the intercalateral arteries on both sides, and there's again no wall enhancement of the middle cerebral arteries or the anterocerebral arteries. And side sequences, again, you can appreciate the clovides of the anterocerebral arteries, so no abnormal enhancement of the vessel walls out there. Post-contrast sequencing was done. T1 sequences was done initially. There's some subtle asymmetry in terms of enhancement of the sulcal vessels, which are better appreciated on the slightly delayed flare contrast sequences. And you can appreciate here there is some leptomeningeal enhancement out there in the right hemisphere, predominantly the right hemisphere, and also in the left occipital and posterior temporal region on the left side. Spectroscopy was done in the abnormal areas. This demonstrated significant elevation, inversion of the lactate peak out there. The voxel was kept in the abnormal areas, not in the normal areas, which you usually see for, evaluate for MELAs. So yeah, abnormal areas demonstrating this lactate peak with reduced choline, creatine, and NA peaks. Yeah, and this sulcal abnormality is predominantly in the right hemisphere. But there's no associated atrophy in terms of asymmetry on the right hemisphere compared to the left. There's no choroid plexus angiomas, and there's no triumphal calcification, which you commonly see at least at this age. The clinical suspicion, I think, was there was no port wine stain for the child. So Sturge Weber's type 3 was, I think, one of the main considerations, if I'm not mistaken, Apura. And the second question was, are there bleeder calcification on the basal ganglia? Those are calcifications. So just the question, does it fit any of these probabilities in terms of clinical findings, or are we just going out with Sturge Weber syndrome?
My favorite is hemiplegic migraine.
Yeah,
definitely. This I've seen a few children. They present like this with or without headache, and the episode can last up to 3 weeks. And the context of headache, hemiplegia, recovery, full recovery, and in the MR you have no diffusion changes, speaks likely for hemiplegic migraine. There are several genetic forms. It can be familial or de novo. The penetrance is variable, and also the age of onset within a family can be variable. We have seen a child with proven CACNA1A mutation, and at the age of 8 or 9, she had already 3 or 4 episodes, and the mother had her first episode at the age of 30. So my suggestion is to do genetic testing for familial hemiplegic migraine. MELAS is unlikely in terms of, I mean, I cannot explain the probable calcification, but you have never seen any diffusion changes.
No diffusion changes, no gliosis atrophy of prior insults. So I think MELAS, even the CSF lactate was very normal.
Yes, CSF lactate was normal, and we had actually acquired MRS from the normal site as well. That also showed lactate peak. However, in diffuse, like if there is diffuse dysfunction, that can be seen as well, right?
Yeah, that can be seen, but the parenchymal changes are not typical for MELAS.
Yes, sir. Yes, sir.
So that is, point against it. Even Sturge Weber syndrome, by this time of, the child is almost 12, 13 years old. If we consider the right hemisphere is abnormal, given it should have been atrophic, they should have been triumphal calcifications. Usually they are seen in around 2 to 3 years latest. But these are again not seen. So again, the choroid plexus changes, the ocular changes are not seen. So I wouldn't maybe put it, and the basal ganglia calcification again is not typical for a Sturge Weber syndrome, even though the port wine stain was absent, and type 3 variants are known to have no cutaneous abnormalities, but imaging does not entirely match with the Sturge Weber syndrome. So I agree with Dr. Bolthauser that I think alternate possibilities, especially hemiplegic migraine, needs to be evaluated. Apurva, anything on the chat? Sorry, I'm not able to see.
Just two questions. One is, were perfusion studies done? And second, can this be Cadicil or Caricil?
There are no white matter changes for Cadicil or Caricil. Parenchyma changes are not there at all. And the age also, I mean, predominantly it is seen in around 20, 30 years or an adult age group. These are not typical changes on the conventional sequences. Perfusion, sure. I don't think perfusion was it done?
No,
Yeah.
sir. Perfusion studies were not done, sir.
Even though, I mean, one of the indirect markers is you can see some particle veins prominence on the abnormal side, or so these are not seen over here on the SWA sequences because of the oxyhemoglobin carried on the abnormal side. So again, these are pretty symmetrical, non-prominent changes out there.
Can I add a note about Cadicil?
Yeah.
There are two forms of Notch 3 genetic conditions. One is de novo or dominant, leading to stroke or stroke-like episodes, rare in pediatric. And there are B-allelic, recessive Notch 3 variants with a severe condition with bilateral kind of leukodystrophy-like appearance, completely different as in this child. When you go for genetic testing for hemiplegic migraine, you may also ask to look at Notch 3.
Okay. Okay, sir. We'll keep that in mind.
The other comment was EEG showing focal slowing and MRI perfusion defect during the episode is usually helpful if it is a familial hemiplegic migraine.
Yeah.
EEG was showing generalized slowing, not focal.
Yeah, in the acute phase, they do show perfusion abnormalities. But again, one of the other markers is they usually are associated with SWA changes too. Not ruled out, but yeah, we don't have perfusion. So to conclude, I think the next step would be to go for genetics. Think of these, I mean, the alternate possibilities, particularly hemiplegic migraine, and as Dr. Balthazar mentioned, RC also to be included in the panel.
Okay, thank you.
Okay, yeah. Please get back to us if you have a diagnosis, Dr. Shikana. Yeah.
Yes.
Thank you. All right, next case, to Rainbow, Vineet, if you're there.
Yes, a very good evening, everybody. We had a 9-year-old child who presented to us with chronic febrile illness, evaluated extensively outside. So after almost a month of illness, he got admitted with us last week. So fever for a month, initially had 4 to 5 episodes per day. Later, with some treatment that had taken outside, which subsided to 1 to 2 episodes per day of mild to moderate grade fevers. And just 3 days before the admission, he started complaining of this headache, which was holocranial present even without fever. And normal examination documented outside, and underwent again extensive evaluation with blood culture, Vidal, Wheelflex, leptospiral, and Brucella serology EBV. And the only finding which they were able to find was with the bone marrow biopsy, which had shown some parvovirus inclusion bodies. However, there was no clinical or laboratory evidence of parvovirus infection as such. So here on examination, it was pretty evident that meningeal signs were certainly prominent with neck rigidity and Kernicks, which was present 1 day before the admission as well. This was almost on day 32 of illness, along with left lateral gaze restriction. So MRI was done in the outside hospital, and films were reviewed, and it was normal. And we repeated an MRI based on these examination findings, which showed.
Suspecting anything particular other than meningitis?
Nothing, no pointers
Okay.
for inflammatory as well. Only infective cause was suspected.
All right. Yeah, MRI done. I think this is the day of 1 month after illness. If I'm not mistaken.
Yes, this was on day 34.
Okay, fine. All right. Flare sequences on top, and you can appreciate there's some dilatation of the lateral ventricles, some rounding of the temporal horns, some periventricular hyperintensities out there. The aqueduct and the cisterna magna, the cerebral medial junction is patent. There's no obstruction out there, but you can appreciate again on the coronal sequences, some rounding of the temporal horns. If you go look at the basic frontal region and the region of the optic chiasm, there are some hyperintensities which will be better appreciated in the subsequent slides. In terms of focal lesions, no parenchymal lesions in the brain or supra-intertemporal brain. And yeah, midline structures are normally formed. Some degree of volume reduction in volume or prominence of interfoliar space is non-specific at this point, and prominence is magna. Post-contrast study, I think these are the suggestive images. You can appreciate, particularly in the region of the chiasm and the optic chiasm and the optic nerves on both sides. There's long segment enhancement of the optic nerves, chiasmatic enhancement, also enhancement of these MCA cisterns and the basal cisterns out there. And the cranial nerves, almost all of them demonstrate abnormal enhancement going from the second cranial nerve to the third cranial nerve up to the seventh and eighth cranial nerves. So all of them in the cisternal segments demonstrate some degree of enhancement. And on the side sequences, you can again better appreciate the optochiasmatic involvement of the abnormalities or the exudates out there. No meningeal enhancement in the other areas of the brain, and no ventricular enhancement or ventriculitis on the post-contrast study. With that imaging thing, we thought of likely diagnosis of tuberculosis presenting in an optochiasmatic arachnoiditis type pattern, predominantly presenting in that pattern. As you can see outlined over here in the schematic, there's predominant involvement of the optic chiasm and also the cisterns, basal cisterns. The other differentials, though thought was less likely, were other infective etiologies. Yeah, these are the differential considerations. But on imaging, we are thinking of a likely possibility of tuberculosis to be considered. Yeah, child was evaluated. Yeah.
With this evaluation, Montu turned out to be positive. The gene expert for CSF and gastric aspirate was negative. ESR was 31, and there was no, and CSF which was done showed significant protein elevation of 388 and 280 cells with 75% lymphocytes. Pardon me for not putting the eye examination findings here. The clinical findings when visual acuity examination was normal. However, there was left lateral gaze restriction, and VP done showed bilateral prolonged P100. This was around 120, and fundus examination showed early papilledema. So the question with this particular case is more of clinical than radiological, since chiasmatic arachnoiditis is known to have a poor prognosis and poor response to treatment as well. Just wanted to know the experience with other centers. And this child, we started on pulse methylprednisolone and started on thalidomide as well. So wanted to know the prognosis as to how other centers have dealt with this particular case.
All right. So from the same review, this was what they mentioned in prognosis. Out of the published cases, around 122 reports, what they found was 85 had available data and 68 of them showed improvement. 14 did not show improvement, and death occurred in 3 cases. So at least in this cohort, this was the prognosis. But yeah, I'll open it for discussion. Prognosis in terms of vision and also in terms of overall mortality, is that right, Ravina?
Yes, sir. And response to thalidomide.
Okay.
You said the visual acuity was normal, na? Visual acuity of the child?
Correct, sir. Visual acuity assessment was normal.
So basically, what we follow, there is something which is known as Valor grading for TBMH, tubercular meningitis and hydrocephalus. So there are some 4 grades. 1, 2, 3, 4, 4A, 4B. So based on that, you have to classify the child. What your child looks like is, I think, grade 2. So you will have to do a EVD first for hydrocephalus, and then once it is done, once the infection is cleared, you will have to convert it into a VP shunt. And if the premorbid vision is normal, then you can have a good prognosis. If the premorbid vision is lost, or if there is optic atrophy at beginning, hydrocephalus, basically papilledema goes into optic atrophy, then the prognosis might not be great. But if it is early papilledema with your ATT, DEXA, and thalidomide with EVD followed by VP shunt, the prognosis could be better for this child.
Okay, sir.
So the thing is, what usually happens is TBM with hydrocephalus, we feel that EVD or VP shunt should not be done, but it has to be done. You have to drain the thing. You have to manage the pressures.
I think Dr. Sridhar, I think the what you said is absolutely right. In a typical case of meningeal tuberculosis with hydrocephalus, here I think the point we want to ask is it is predominantly opticochiasmatic, which is symptomatic. Right, so fever is there, which is systemic manifestation, but locally, if you see a lot of cranial nerves are showing enhancement, and the optic nerves also have some subclinical involvement already. So, because this is not a straightforward meningeal TB with hydrocephalus, there is a disproportionate involvement of the basal regions.
Basal regions.
Yeah. So that's the
Yeah, but they will give good response to thalidomide. We usually used to use dexamethasone as it has a better anti-inflammatory action, and we used to taper it over 3 to 4 months. A longer taper than what usually is recommended is 8 weeks as per the American guidelines. But we used to give it over 3 to 4 months taper.
Is
Okay,
it sorry?
No. So please go on.
No, is it a what TBM with opticochiasmatic arthritis?
Yeah, it is.
Yeah, so I mean, you should use infliximab. If the child is losing vision, infliximab is a good idea.
Clinically, his visual acuity is normal.
Oh, it's normal. Then it's fine. That's
but
fine.
VEP shows prolongation of P100 latency.
Yeah, so I mean that's okay. You can monitor it if give him steroids and thalidomide or whatever. But thalidomide has been used in South Africa and they reported very good results. But frankly speaking, I have tried it, but I've tried it late in 2 patients who are already blind and they remain blind. But if you started early, maybe it'd be good. Prevent it.
Okay. So in case if there is any clinical worsening, you infliximab.
Yeah. We just used it in this paradoxical reactions.
Okay.
And they also, it helps a lot. So it's steroid dependent also. Okay.
Any experience with hyaluronidase, intrathecal hyaluronidase for opticochiasmatic?
I think Gauri Shankar or somebody from, she used to use it in Bangalore, Nimans, but I think nobody really experienced any, I mean, it went off. I don't think there's any real improvement. But infliximab, there are a lot of papers on in TB, but
okay.
Obviously there's a little problem because the infection may persist, or there's always a chance the infection may worsen. Okay.
The Shiji has messaged thalidomide given in 2 children, near complete improvement. Dr. Shiji.
In hyaluronidase?
No, I think thalidomide.
Thalidomide, yes. Thalidomide has been, as far as South Africa, has been published. There's papers published on opticochiasmatic iridocytis, I think from Roger Solomon or something his name is. Look it up.
So do you also suggest if asymptomatic but radiologically it's present like in this child, infliximab?
No. I think if it was going downhill, I didn't know. I just joined the session. If it is worsening, obviously then only.
Okay. Sure, sir. I think we'll keep a close monitoring.
Yeah, start thalidomide.
Yes, thalidomide and methylprednisolone we have given 3 days.
Sure.
Thalidomide we started.
Okay.
Thank you.
Yeah, Dr. Ramesh, I think just going through the chat, we discussed one case previously in 2025. As Dr. Shiji has mentioned, that time also she had given for 2 cases thalidomide. And also, I think Dr. Jayashree also had given thalidomide, which had good response. And Dr. Anaga Bhagwat, I'll just maybe share the chat with you. They all have given thalidomide with the good response. Dr. Vivek had mentioned at that time to give infliximab, Dr. Udani has mentioned. So I think, thalidomide and steroids. I think infliximab.
I think both are TNF blockers. So.
Yeah. Thank you.
Right. Okay, Vinit, what do you?
Yeah. Coming to the next case, 9-year-old a child who got admitted to us last month, PICU. This was on Jan 13. Pre-morbidly, totally normal, no significant perinatal issues, no family history. Fever for 2 days, which got subsided, and on day 4 started having mild encephalopathy, and had in one episode of seizure. This was in the form of like left focal motor seizures, for which he was admitted at a local hospital. Then on day 5, had 2 more episodes of similar semiology, and this by this time the encephalopathy had worsened. In that he was not responding to commands. One of them had right focal status as well, lasting for almost 30 minutes, and shifted to our hospital. He was brought comatose to the emergency room. He was intubated. CT brain, which was done on the day of admission,
Oh, I don't have the CT
was
brain, sorry.
this was normal, sir, a normal study.
Okay.
We could not find any clues on this CT brain, and gradually child evolved into superrefractory status epilepticus as well. Even after starting on midazolam and ketamine infusion, he was then started on isoflurane, escalated till MAC 1.2. This was by day 3 of admission, and we proceeded with immunomodulation as well, IVIG as well as Pearl steroids. And later, however, there was no apt response to the treatment which was being given, and this SRSE got converted to prolonged SRSE as well, lasting for more than 7 days. And MRI brain, which was done after a week of SRSE, showed.
All right. A week later, mean changes on the diffusion media sequences. We can appreciate either the restricted diffusion, the bilateral hippocampi, and no other abnormalities in the brain parenchyma. On the T2 sequences, some degree of tail volume loss, no lesions, no structural malformations, no focal abnormalities. So main findings are the diffusion changes and some degree of generalized, more cerebral than cerebellar volume reduction. At that point of time, I think the clinical possibility mentioned was fires or NORS as one of the possibilities, and for bilateral diffusion-mediated sequence, changes on the hippocampi, these are the possibilities. Autoimmune or immune-mediated, infectious, and less likely toxic-related changes. So I think, if I'm not mistaken, fires was mentioned as one of the possibilities, and we thought that the imaging kind of matches the clinical diagnosis of fires. Is that right, Nihaal? That point of time?
Yeah, that is right, sir.
Yeah, so hippocampal changes are commonly known to be seen in fires, along with other additional findings as the disease progresses. So yeah, the changes corroborate with the clinical findings. Then in between, there's one more scan.
So in between, the frequency of seizures was the same. There was no significant improvement in the seizure burden as such. The child had seizures lasting for almost 15 to 20 seconds, up to 45 times per day, even with immunomodulation and general anesthetic inhalation. So up to day 31, the seizure burden continued the same, and MRI brain was repeated on day 31 of admission. This particular imaging was undertaken to see regarding the status, neurological status, and whether how high should we go on the treatment escalation.
Right. Follow-up imaging, you have interval progression in terms of imaging findings. Now more involvement of the basal ganglia, the fornices, the claustrum and the external capsule, some degree of involvement of the deep white matter, frontal and parietal white matter. Coming down inferiorly, you have some abnormalities in the right temporal horn along the areas of the choroid plexus. I think better demonstrated on the SWA sequences. Again, some changes of cytotoxic edema in the cerebral peduncles, on the contralateral, bilateral mesial temporal lobes. And also the cerebellum you can appreciate here is demonstrating these areas of edematous changes. Some focal abnormalities in the occipital subcortical white matter. On the T2 sequence, again, corresponding changes, what we have seen on the diffusion sequences, so basic ganglia involvement, subinsular involvement, some thalamic involvement, and coming down to the medial aspect of the temporal lobes, again, you have these edematous changes. The hemorrhagic changes along the temporal horn of the right lateral ventricle in the region of the choroid plexus. And posterior fossa, again, you have edematous changes involving the brainstem and also diffusely involving the cerebellum, the dentate nuclei. SAD sequences, you can appreciate the extent of involvement of the brainstem. We have spinal images, so there is also spinal cord abnormalities, which will be seen on subsequent slides. On the SWA sequences, you have microhemorrhagic foci along the parasagittal regions on both sides, the pericallosal regions and the corpus callosum. And again, you can appreciate the intraventricular hemorrhage as seen on the bottom panel, and some again areas of microhemorrhagic foci in the left temporal lobe along in the brainstem, dorsal brainstem. So some microhemorrhagic foci and main changes of intraventricular hemorrhage in the right lateral ventricle. This is a plain T1 empirage, and this is post-contrast T1 empirage. And you can appreciate again T1 hyperintensity of the right lateral ventricle in the temporal region. This does not demonstrate enhancement because it is T1 hyperintense on the plain study itself. But there was some focal enhancement in the medulla, and no other regions demonstrated any areas of abnormal enhancement. Spine was done, long segment myelopathy of the spinal cord over the entire extent. On the axial sequences, you have predominant involvement of the central gray matter. Also, the dorsal columns it demonstrated some areas of involvement, but yeah, main changes are in the central gray matter structures and also in the dorsal aspect.
So, with such extensive involvement, our differentials was worsening sepsis, HLH, demyelination, probably drug-induced. For sepsis and HLH, however, we did not have any laboratory parameters which were suggestive. And serum NMO-emoji, which was turned out to be negative as well. We got the
Sorry, wait, I think I lost.
Are associated with such findings. Wanted to know experience with other centers.
Sorry, wait, can you just go back if anything for me? So I think I missed it.
Oh, just the investigation, sir, which I've
Okay.
already told. Oh, I've
Okay.
told orally. Yeah.
Okay. So I think the question radiologically was, could it be drug-induced intrathecal dexamethasone? I could not find any reference for this in pediatric patients and such an acute or subacute stage. And what are the possible other causes of the spinal findings? I mean, overall pattern we're thinking of, yeah, as Vinita mentioned, sepsis-related changes causing the hemorrhage. HLH, I think, was suggested, but the markers did not correlate with that. And inflammatory and infective pathologies with the overall brain and spine appearance was considered radiologically. And going by the questions of differences for myelopathy or radiological findings of the spine, our child predominantly has central gray matter changes. So it can be seen in parainfectious changes and some abnormalities involving some viral infections. The dorsal column involvement is usually seen in nutritional deficiencies. Beneath any of these demonstrating nutritional deficiencies clinically for the child?
Oh, sir. No, sir.
Okay, no vitamin B12, right?
No.
Okay. Yeah. So yeah, these are differentials for the spinal cord changes. And overall pictures, as mentioned, inflammatory changes in the brains, predominantly in the posterior fossa structures and also supratentorally. So yeah, we thought this was the possible contributory changes causing these findings. Yeah, I'll open the
Can I
case.
make a comment?
Yes, Doctor.
No, intrathecal dexamethasone contains benzyl alcohol, I think, or propylene
Yes,
glycol.
yes.
And benzyl alcohol or whatever. I don't know. This
Benzyl
is
alcohol,
not
yeah.
supposed to be used. This is not
Methyl,
supposed to be. This is not supposed to be used
me.
intrathecally unless you have preservative free. And I know it's being used left, right, and center in these patients, but the problem is it can cause a severe chemical myelitis. And this well could be a chemical myelitis secondary to that. So I think we have to be a little careful about giving this
So,
because Japanese people have given it, but they had dexamethasone preservative free. We do not have that. I've checked this before. I was also given one patient, but we never knew whether we gave him myelitis or not because he never recovered. In the sense, he just passed away at home. He never woke up only. But basically, the problem is, I think we have to be careful.
Yes, sir. Actually, intrathecal dexa, we consulted with hematonco people as well. They're using it quite frequently. As you told, most of it is off-label only, even though no case reports on that. And do we have preservative-free dexamethasone available in any way?
No, we don't. We don't. I've checked all over. It is in India. We don't. There's a lady from Belgium who was in the ICNA. She also was asking the same thing whether we have it in India, and I checked that time also. It is not available. So if you want to use something, maybe you can use, I don't know, methylprednisolone comes with, you know.
Yes,
So I
sir.
think it's Methylprednisolone come with I'm sure all these come with preservatives. That's the problem. See, we should have the same problem with
Yeah.
intrathecal methotrexate. So intrathecal methotrexate gives a severe myelitis.
Yeah,
which
methotrexate, yes.
with the same agent, some propylene glycol or whatever it is.
Okay.
So it gives, and we had a bunch of patients from Tata where they were giving this thing. Then afterwards, the whole thing was changed, and now we get preservative-free methotrexate, and this become much rarer now. It can still cause methotrexate by itself can cause the dorsal myelitis, but it's become much rare. And this looks like cerebralitis also.
Yeah, cerebralitis and also brainstem.
Yes, sir.
Yeah.
So dorsal column, I think maybe, but rest of the findings, yeah. Okay, I don't think anyone has any other further comments about intrathecal dexamethasone with imaging findings. Maybe
Yeah,
we'll
I
have
think
to.
although we cannot
Yeah.
prove it, but that's
Yeah,
a
we
very
cannot prove
much
it. Yeah,
likely possibility.
yeah.
I think yes, that
At least the
Udani said
dorsal
you should be
column.
very careful.
Yeah. I agree. All right.
But I don't know if it's temporary or not. I really don't know because, probably not. It's
It
probably
is.
permanent.
We hope it is not, but
And
it is very scary
it's not like it
because
happens to everybody. I don't think it happens to everybody. It's just a side effect which we have to be very careful with. Now, I know people use it off label and you might not get it, but it's like.
yes, sir, but this child's seizures were getting controlled. Only stimulus-induced movements were there, so we thought we can get him off all the anesthetics, but still he was not waking up. So no brainstem function. So we had to take a call.
I understand. I mean, this is a risk you take. No, I'm not saying it's a wrong thing to do, but problem is we have to be a little careful.
Yes,
I don't know about this hemorrhage. What is it? I've never seen hemorrhage in fires. Have you?
No,
Nihaal?
the child has sepsis also. Subsequently.
and J sepsis, systemic sepsis, some thrombocytopenia in between, and maybe that could be a contributor.
Yeah. Because the
And
initial
this
scan did not
myelopathy.
have, initial scan did not have any hemorrhage. I think subsequently, once the child developed all these, sepsis, maybe that could be contributing.
This myelopathy was completely out of loop.
Yeah.
Such an extensive myelopathy.
No organism detected.
No, nothing.
Okay.
No organism.
Oh, thank you. Then we can move to next.
Yeah.
Thanks.
Wait, sorry.
Hello. Yeah. So this is the term child. 3.8 kg. The cesarean was done in the view of PIH. Child cried immediately after birth, but there was a respiratory distress because of meconium stained liquor. So child was given low flow oxygen for 4 days. Then the child was discharged. On day 6, the baby had 3 apneic episodes with encephalopathy and poor feeding. So again, he was admitted and shifted to CPAP from low flow. On day 7, again had 1 apneic episode that was requiring bag and mask ventilation, and after that, child was intubated and put on ventilator. So on the same day, child had 3 episodes of seizures, 2 in a cluster, followed by 1 more episodes 4 hours later. Though this occurred in the referral hospital, so they were telling the simulology be like generalized tonic-clonic seizures. Child was extubated 12 hours later, and on the same day, the child was referred to us for the further management. So the examination at the arrival was AF was at the level. There was a signs of encephalopathy in the form of no spontaneous eye opening, paucity of general body movements, sustained tactile stimulation required for arousal and grimace. Nasal was present, extraocular movements were there. Bilateral pupils were normal. Facial symmetry was there. There was generalized hypotonia. Symmetrical anti-gravity movements were there, but reflexes were diminished, and morose was absent. So investigation-wise, infective parameters remained normal. In the view of encephalopathy with seizures, with the CSF that was showing, protein was 156, glucose level was 48 against the GRBS was 70. Cells were 14, all were lymphocytes, and culture remained sterile. TMS ammonia lactate were normal. In gram stain, no cells or organism or yeast. Zerine was normal. Blood culture was also showing no growth. So MRI brain was done.
Yeah. And if you can
after
just
2 days,
summarize,
which showed.
if you can just summarize what we're thinking
Hello.
clinically. Can you just summarize what
Yeah.
we're thinking clinically?
So this
based on the
based on the findings, initially we thought because of that acute event, we initially thought of any infection or any hemorrhage. So NSG was done, that was also normal. So our diagnosis was infective.
Okay. And no
Yes.
hypoxia related change. I mean, you say
No. Yeah. Because the child cried immediately after birth.
Okay. No, I'm
Yeah.
thinking after their birth. Nothing
Yeah.
significant.
Nothing significant, sir. Yes.
Okay. All right. These are the MRI images. On top of the diffusion media sequences, we can appreciate multifocal areas of restricted diffusion in the centrum submucoid on both sides, posterior periventricular white matter, peritrigonal white matter on the left side. No corresponding changes on the stabilized sequences of those focal abnormalities. And no other areas also. You can appreciate these do not demonstrate any areas of blooming. On the T2-weighted sequence, I thought for a term gestation, there was some undermigration, some possibly mild simplified chiral pattern. But other than that, no other significant findings seen. So main findings were on the diffusion-weighted sequence. I think contrast wasn't done for this style. Contrast was done. So this is plain T1 on top and contrast on bottom. And on the plain T1, you can appreciate the lesions itself are hyperintense predominantly on the periphery. The smaller ones demonstrate more homogeneous T1 hyperintensity. So intrinsically, they are T1 hyperintense. So on the post contrast, this does not represent true enhancement because on the T1 weighted sequences itself, they are demonstrating hyperintensities. So this would be categorized as no significant enhancement on post contrast study. So T1 hyperintense changes with no SWA sequences, no blooming on SWA sequences with areas of restricted diffusion. At that point, we thought that these are representative of some degree of punctate white matter lesions. Could be possibly secondary to an infective etiology, more viral was a consideration. We can also be seen in mild hypoxemic changes, sepsis-related abnormalities, and some degree of cardiac abnormalities. So these were the differentials we thought on imaging. And I think child was evaluated subsequently. Anything else, Nikesh, after the scan?
No, sir. We thought of sending. We will send the CSF PCRs also. The results are awaited.
Okay.
But in the view of that ring-shaped lesions, we are thinking what could be the differentials. Yeah.
So these are not abscesses per se. These are more. There are more necrosis or ischemic changes out there. But yeah, given the diffusion changes, I would think infection could be a possibility.
Okay, sir. Any other specific viral infection that can give this radiological picture, sir?
If it was more confluent, I would have probably said those typical paricovirus, rotavirus, those type of viruses. These are more focal, but maybe a milder version of those.
Can this be toxoplasma?
But it doesn't. I mean, they do not show T1 hyperintense on plain study data.
Because that can cause granulomatous lesions like this.
No, but these are not enhancing. That's fine.
Okay.
So these are T1 hyperintense on the plane itself. So this will not consider as enhancement.
Okay.
So
It
because
just
it's already
bright.
it is bright because it's already bright on T1. So that is just So
is it hemorrhage?
It does not correspond on the SWIs. So radiologically, what we term is non-hemorrhagic punctate white matter lesions, the PWML types. Yeah. Any other
Okay,
thoughts?
sir.
Case is open. Yeah, if they want to make. We have sent for PCR, Nikesh?
So
Yes,
there
sir.
this
We
could
have
be
sent
just
for.
a non-specific
Yeah.
changes of, say, can be hypoxic ischemic.
Yeah, it can be mild hypoxic ischemic, but this
Okay.
child is a term gestation. That was one. But these can again be seen in infection. Viral is common. Sepsis again is a common finding, and underlying cardiac abnormalities can also present with these. But they are usually more hemorrhagic than non-hemorrhagic ones. But clinical suspicion of viral, I think that, infection has to be, yeah.
I think Dr. Sridhar, what he messaged, punctate white matter changes are very. So you were talking probably about DAISY, is it?
No,
Diffuse
DAISY is
excessive.
different.
That is.
DAISY is more cap-like lesions along the periventricular areas. These are more commonly seen in preterm children.
I have shared the paper of Dr. Linda DeVries. She has done a systematic review sort of thing on all these changes. So they found multiple causes. Hypoxia was one of the etiology, infection, then some SLC 35A2 gene was there. So a lot of differentials were there, but they could not point out a specific etiology based on this. A pattern. It is not a pattern recognition sort of thing. I have shared the link on the chat.
Okay, sure. Thank you.
So Nikesh, let us know if you get any organism on the
Yeah, sure.
Yeah, thanks. All right, over to you.
So yeah, so another case we like 1 month-old male child born of non-consanguineous marriage came for review of MRI reports. Actually, child was active, feeding well. The movements were good. Child was on mixed feeds. There was good swallow suck and sleep was good. Child was born first birth order. Elective LSCS was done at the age of 34 weeks due to oligohydramnios. Child cried immediately after birth. Birth weight was 1.75 kg. There was history of neonatal jaundice for 3 days. No history of restless hypertension or thyroid in the mother. History of gestational diabetes mellitus was there, and mother was on a dietary therapy for the same. So on the examination, HC was 31 centimeter, just touching the line of third centile according to the Fenton charts. But there was early hypertonia. Reflexes were good. There was good active recoil. But MRI brain was done during fetal life as well as on the first day. During fetal life because of ventriculomegaly, and on the first day of life because of the fetal MRI was showing some changes.
Okay. So
I think
fetal
because of
scan. Sorry.
In the second trimester, because of suspicion of unilateral ventriculomegaly, they had done an MRI, fetal MRI. But subsequently, the peri-intrapartum, there is no significant events. So just to follow up the antenatal findings, they did another scan postnatal.
I think the fetal MRI was done again. I have the latest one, Dr. Somesh. I think it was done in third trimester.
Okay.
Because I checked the timeline. It's around 20 days between the fetal scan and the postnatal scan.
Okay, almost towards end of gestation.
Yeah, almost.
Okay.
So 34 weeks or maybe around 32 weeks or 31 weeks, they had a fetal scan. Not sure how the images project, but so these are diffusion and the ADC sequence on the fetal. Okay, so this is what the fetal scan. As you can see, there are multifocal areas of cystic changes, periventricular regions out there, and also some clastic abnormalities and some, as we already mentioned, there's some ventriculomegaly, some asymmetric ventriculomegaly. Left side is demonstrating some porencephalic dilatation out there. I think we'll better appreciate these imaging findings, which are also present on the postnatal scan, some areas of blooming on the express sequences, and some hemorrhage, some areas of distinct diffusion within the cystic abnormalities. So yeah, the findings I think better appreciate on the postnatal scan. You can appreciate again periventricular almost porencephalic dilatation, involving the parietal frontal lobes and also the occipital lobes on both sides. Some subcortical changes in the parietal lobes on both sides, more on the right side. Some areas of T2 hyperintensity, this corresponds with the areas of blooming. So ventriculomegaly, again, asymmetrical ventricular, slightly more on the left side. Diffusion, again, restriction more on along the periphery of the frontal abnormalities and also the left posterior parietal abnormality. Yeah, these were the main findings. No structural malformations per se on these images. Yeah, plate sequences, again, you have CSF, refractory changes of the cystic changes, which we've seen predominantly, again, parietal lobes, occipital lobes, and some heterogeneous areas of changes in the frontal lobe abnormalities, which correspond with the diffusion various sequences. Some linear areas are seen within the cystic changes, possibly corresponding to medullary veins, though this does not demonstrate any blooming on the SWS sequences in these regions. Focal abnormality in the thalami, more on the right side. There was, for this gestation, there was some cerebellar hypoplasia and some prominent sternum out there. So, yeah, main findings is multiple plastic abnormalities with some porencephalic dilatation, asymmetrical ventriculomegaly, some areas of restricted diffusion within the cystic changes. Yeah, more along the periventricular, more predominantly in the periventricular pattern, going up to the subcortical cortical regions with some cerebellar hypoplasia. Yeah, clinical thoughts with, thought of was it a deep medullary vein thrombosis with hemorrhage? We thought, yeah, possibly contributory factors were venous ischemic changes with hemorrhagic abnormalities. Etiology-wise, these were the, I think, what thought would be considered for any abnormalities in the prothrombotic or related states, any risk factors in the antenatal period, and also genetic disorders such as Pol4A1, Pol4A2 to be considered based on the imaging findings. So these were differences we thought of. Not sure what has happened subsequently. Any labs or was done or any investigations were done. Nikesh, maybe you can fill us in and
yes, sir. Yeah, we have think of that call for A1 related mutations, and we have sent the whole exome sequencing for the same.
We just saw this maybe this week only.
Okay.
I think early this week.
But no baseline hematological abnormalities.
No.
Or is it not expected?
No, there's no hematological abnormalities.
Okay.
Even call for also we don't see anything
in
the peripheral.
So thrombophilias and all that goes back.
Yeah, but there are hemorrhages also.
Yeah,
yeah. Thrombophilias are also possible, especially protein C deficiency can cause both deep medullary vein thrombosis as well as hemorrhagic conversion. So that should also be picked up in whole exome.
Case open, any thoughts or comments, please speak.
So only with call for, only one question was, can it be so symmetric? This is quite, generally we see asymmetric hemorrhagic lesions or cystic changes. This looks very
the frontal ones, call for can involve deep medullary veins, so maybe that is there, but the ones over here, at least here, right side is more, again, ventriculomegaly also is more on the left side. So I wouldn't say completely symmetric except the frontal lobe ones. The other ones I think are slightly asymmetric out here.
Okay. So there is some progression from fetal to postnatal, is it?
It will be difficult. So fetal, we had some, hemorrhages on the deep brain nuclear structures, which are not seen on now on this change. But I think overall, I think it looks pretty same.
Again, you can see more cystic changes in the postnatal scan than the fetal one, isn't it? The parietal ones, bilateral.
Yeah, the parietal ones, I guess. Or maybe the fetal, resolution also more in the postnatal scan is better, but I agree. Okay, yeah. Any comments or any other possibilities to be thought of? Okay. All right.
So we'll update you once the genetic reports come.
Got it. Okay. I think that is our...
I think there is one question in the chat box about when to ask for fetal MRI when ultrasound shows ventriculomegaly. What is the criteria? So I think if it is a say unilateral mild isolated ventriculomegaly, if there are no other suspicious findings on fetal ultrasound, like any Katka malformations, corpus callosum, or posterior fossa abnormalities associated, we may not do because the yield is low. But if there's any other associated findings, we can ask for better delineation of other associated malformations.
Usually second
Dr.
trimester is the
Nihaal,
best time.
yeah,
Sorry.
yeah. So you want to add anything?
Yeah, usually second trimester is the best time. Usually better to avoid the first trimester. At least after 20 weeks, it's better to evaluate malformation per se. But I think also the indication of scan may also be dependent upon the parents' anxiety. Sometimes even the mild ventriculomegaly, they come for fetal scans. So yeah, as in mild is fine, but I think if it's mild less than 10 to 12, we can monitor them on the ultrasound itself. But if there's some asymmetry, if there is significant disproportion, then I think fetal MRI is indicated. Okay, if there, sorry, I cannot see the chat, but if there are no further comments or sorry, we'll, I
There's
think,
one question
So one
about
question
sorry,
is
yeah,
that
Just
My
one.
question is,
yeah,
sorry.
sorry.
Go on. You finish.
is the infection of parvovirus is a possibility for a virus.
Varico possibility on diffusion, but they usually do not cause hemorrhage. So yeah, that common being common, typical imaging being typical, it usually show demonstrates diffusion changes, but hemorrhagic changes, plastic abnormalities are slightly atypical for varicovirus.
Hemorrhages and such extensive cystic
Yeah,
changes are
yeah,
uncommon so early.
yeah,
Later, they
yeah,
may go into gliosis,
yeah.
but not this extensive cysts.
Yeah, I had a question. I mean, we commonly see this periventricular venous hemorrhagic infarction.
Yeah.
You may get some monoparesis, the leg or something of that sort. So, question is, should we do code for A1 to all these kids?
If it is only the isolated thing, then maybe the likelihood is less likely. Because associated usually call for the giveaway for on imaging wise is the cephaly, porencephaly, colpocephaly. I mean, not colpocephaly, but porencephaly, asymmetry, calcification, hemorrhage. Those associate findings usually give away for call for. The isolated periventricular hemorrhagic infarction, yeah, I'm not sure of the yield of call for.
Think, sir, what you are probably asking, even in some of the HIE cases, you can see
Okay.
congestion of medullary veins and some
Yeah, slow.
micro
Yeah,
hemorrhages.
yeah.
No,
Slow
I
flow is there.
understand that, but I'm saying, is it that if you have this mutation, I don't know whether it's been done studies in this kind of patients, because maybe somebody can check if it's done.
Sure, sir.
Yeah.
I'll check and get back to you.
Yeah.
Okay.
Thank you.
Thank you. Thank you very much.
Thank you, Dr. Nihaal.
Thank you, Dr.
everyone.
Mish. Yeah. Thank you, everyone. Thanks for your cases. All right. We'll meet again in 2 weeks' time. Yeah. Till then, see you.
Bye.
Bye-bye.
Yeah.
Rajkumar, you can end the session. Thanks.